I'm from Sault Ste. Marie, and so coming to the mountains is always a place of coming home. And again, I thank Susan and the organizers for allowing us to come and share a little bit about our story and what's going on. And it's really good to see everybody. How's everybody doing this afternoon? Good? Good. So I find it ironic that I'm speaking here at the Banff Center because I left the Bow Valley in 2009. I worked with the Stonies for 7 years in many different capacities out here in Morley and lived in Canmore. So it's very quaint that you actually have recognized the territory. And I also want to recognize some of the elders that have contributed a little bit to my worldview and learning about what it is to work in a health context from a holistic view. So I stopped earlier today to be able to go see the late Albert Coquitz and the Coquitz family from the Wesley First Nation as well on my way out. And also an elder in Cochrane that's passed away. His funeral will be on Tuesday, the late Jack Tennant. And so those individuals have been very paramount in some of the relationships when it comes to health and well-being and so on and so forth. But getting on to the agenda and the story today, I'm very blessed and happy to be with you guys today and to be kind of back home into the mountains and to share a little bit about the story that we have come up with from an Aboriginal health access perspective. And so, again, I've titled today's discussion or dialogue, because we have such an intimate group. Hopefully we can walk through this together. The ideas around moving from the political realm of infection control and policy and regulations to more of the frontline praxis, because that's the essence of what we've done along the North Shore and in many other areas as we've moved forward with Makwa-wise. And so, again, I'm hoping today that you'll be able to glean a little bit from our story, and then maybe potentially we may be able to work together to do something similar in your Indigenous contexts and work together for the well-being of all. Because Minnow-Bamadswin, from our particular background, I'm Anishinabek from the North Shore, from Mississauga First Nation. Bananaquit's my Indigenous name. Roger's my given Christian name. And so as we work amongst our Indigenous people, and being Indigenous myself, sometimes we don't fit. And sometimes we don't do things according to guidelines, best practices, or in particular, as Vicky, one of my sponsors that asked me to, and co-workers and colleagues here that's helped us along the way with Public Health Ontario, we need to have dialogues about what that really looks like. And so hopefully we can share a little bit of the insights of the success that we've done. So again, any declarations of conflict, I have none at this particular conference or this speech. And I always think it's important to bring my family along with me. So again, I take the time and say thank you so much for my partner, Stephanie, who's here with me today, as well as our 7 beautiful children, as you can see on the screen there. And as amongst the Indigenous people, as you know, family, just as you, is important. And so everywhere we go, I stand here as Roger Boyer, but there's a whole ancestral lineage that stands with me, that came before me, and there will be, as you can see with those beautiful children, there will be ancestors who will follow after me. And so the idea that as we move forward today is that the impacts that we make today is for that 7th generation. That's Anishinabek traditional teaching. And so when we look at infection control, we do things in our particular clinical context for just that particular purpose, so that it carries on and there's sustainability built within it. So I think that's important. So that's a little bit about my family. Some of the objectives, as you've read in the brochure today, I'm hoping to be able to, I don't know whether it's step by step, because I've only got 3 hours, right, Susan, to talk? No. But giving you some ideas around what we've did along the North Shore and what we're continuing to do to spread, because that's the thing. A lot of times, I don't know about you, I've been to a lot of conferences and they say, here's the Big Bang Theory. This is what we did. We made all these innovations. We've changed. We've covered it, or we sustained it for a little bit, and then you go back 2 or 3 years later and what did you do? Well, the good news about this story is that it's continued to perpetuate as I've left in September and moved up to different areas. So I'll share a little bit about that as well. And then around some of the safety concerns we have. So in our jurisdiction as Indigenous people, as you know, it's not just cut and dry. It's not just provincial funding that we have to deal with, or your provincial regs that we have to deal with, but we also have Health Canada regulations that we have to work within as well. So a bit of our story will show you how we blended those 2 worldviews together to work together for the well-being of all. So that's what I'm hoping to accomplish today. But first and foremost, I think it's important that as we start any transformation, so my background is system transformation and really looking at organizational culture as being a means to move and motivate lean quality improvement. So those are buzzwords that really mean that I work beside a bunch of professionals that help you create the system that you want to get the outcomes from. So when you look at transformation or you look at change, I love Arthur's quote here. And the quote is, "Nothing happens until the pain of remaining the same outweighs the pain of change." And so I think it's important today for, again, as a founder of a company called Muckwawise that believes on the authenticity and transparency and empathy of our healthcare system, that I share a bit of a personal story with you, if that's okay. Is everybody okay with that? Okay. So in May 27th of this year, I weighed in at 252 pounds. I have 4 beautiful daughters, as you say. We had a great night at the daddy-daughter ball in Sudbury. Was able to take them all out, and I was the beast, and they were the 4 beauties. And so we had a great night. But unfortunately, a lot of times as leaders, we have all this theory or rhetoric in the side of our heads, but we really don't understand how practically does it come out on the ground. We have surveillance systems all over the place. We have EMR systems all over the place. And I've heard an elder tell me before, we've been data collected to death as Indigenous people, but also in the healthcare system, we have data that we don't even have interpretations for. And so when we look at that particular thing, I think it's always important that as we look at system transformation or system change, which is our story, that we have to look at the authors of that particular change. And so me being a leader in my particular context, I needed to look at some change. So believe it or not, a year ago, I was 400 pounds, 396 pounds to be exact. And so within 338 days, I've been able to change my life and transform my life by the basic principles that I'm going to share with you that I'd like to outline very briefly in what we call relationship. And I'm pressing the wrong button. So the idea around transformation from my particular context is the areas around around relationship. So what I want to share with you is the acronym that we came up with, the step-by-step process that I'm going to share this afternoon about relationship. And so when you're looking at transformation, relationship is important because why? You don't do this on your own. How many of you are lone rangers in your agency doing infection control? Really? How's that working out for you? It's not easy, is it, right? And so when you're looking at making systematic change, I always think it's important to remember those that have walked the journey with you. So I'm going to bounce back and forth here and go back to this particular slide. So one of my key colleagues that helped me along the way was a lady by the name of Lois Harrop. And so Lois and I basically were given the task to be able to look at how can we inject or transform our primary healthcare system to look at contextual guidelines within an Indigenous context that is not non-compliant to both the provincial and the federal regulations. So Lois helped me, so I want to thank her publicly for that because we've been doing this now for the last 3 years working together. And so Lois helped me out. And then Vicki and her team, Vicki's sitting up here at front. She's worked for Public Health Ontario. Vicki and her team, Lori and Rebecca. Rebecca still is a rock star to this day. Has helped us to continue to spread and provide support with the tools that PHO provides. And then also just the 7 First Nations along the North Shore that we worked with. And now the 4 that we continue to spread to work with in Wawa and Chapel. And like I said, I'll share that a little bit later as I go through. But I think because it's a national conference, I think you need to understand the context of what's going on in Ontario. How many of you are from Ontario? Okay, so not very many of you. Miss Woodstock, good to see you again. So the idea in Ontario is what they've done in the Indigenous populations is paramount to anything that's going on in the nation right now, even to what I would say would challenge Joe Gallagher and the First Nation Health Authority, because what they've done in Ontario is they've not only said, hey guys, we're going to give you the funding and the resources to do health transformation, but guess what, even better, you're going to create the system transformation from an Indigenous worldview, and actually 20 years ago made an investment in what we would call Aboriginal Health Access Centers. And so these Aboriginal Health Access Centers and 3 community health access centers basically are the mitochondria are the powerhouses in Ontario that carry the bundle for transformation for Indigenous healthcare. And so I worked for one of those agencies called Mamawezing, and that's our story that I'm sharing with you today. So the context in particular that we're working in is in a primary care sector, working with 86 different individuals across the span of about 603 kilometers. And then when we added the other 4 clinics on, the total kilometers duration that we were looking at was about 831 kilometer base. And so if that's not a challenge from an infection control perspective, when you have a multifaceted approach, I don't know what would be there. And so, again, we took on the challenge, and we, again, hope to share the story. So that's a little bit about the context. This is graphically where we're from and where I'm from. So Mississauga, as you can see, it's right in the middle there by God's Island, that beautiful Manitoulin Island, and the 7 First Nations along the North Shore between Sault Ste. Marie in Sudbury. So that's the particular context that we're talking about. And you can see that other First Nation up there called Temiskaming or Temigaming, or what we call Bear Island. That particular First Nation right next to it is our northern reaching point in Chapleau. And so Chapleau is where we were able to spread, and we continue to spread this wonderful innovation that I'm going to share with you. So again, talking about relationship, I want to move on and just talk about the response. So I'm going to give you some of the building blocks of what we did along the North Shore to be able to move infection control into this particular type of healthcare system. And so responding, one of the things that we figured 7 years ago, led by our leadership and our chief and councils, was the importance of us being able to lead health transformation from an Indigenous perspective. No longer were we going to allow the government to tell us how to take care of our people. And so 7 years ago, our chiefs along the North Shore got together, and they allowed for us to be able to go to South Central Foundation in Alaska. How many of you know the NUCA model system of care? If you don't know the NUCA system model of care, I think you need to look it up, write it down. If you don't hear anything else I say today, talk to me after, because from an infection control standpoint, I'm telling you right now, they leverage technology better than anybody I know, and it's 100% Indigenous owned and operated. They were the Malcolm Baldwin Award in 2004, and I think that's one of the best models out there when it comes to integrated primary health care. They service 56 outreach clinics, and so for us, we needed to go and learn. And so again, this whole experience of Mamawezing is about learning and lifelong continual learning. And so in saying that, our chief said, we want you to go, we want you to understand what it means to be evidence-based primary health care. We throw these buzzwords along a long time, but unfortunately, I was sitting at a table over the lunch, and we're still using Excel spreadsheets to track and surveillance. How many of you are still using the Excel to do that? Right? So it's time, it's 21st century, guys. We all have one of these things. It's time to start looking at how we can do it better and mobilize that. So we're going to help you. So as a part of our response, we had to go somewhere else to learn how to do that. And so we took a delegate of about 33 different people up there to Anchorage, Alaska, to understand a little bit more about what it meant to actually own and operate your own healthcare system. So the first response in this particular project was that we needed to understand what was infection control in an Indigenous context. Like when you look at primary healthcare and you go to your doctor's offices, you're not really concerned about infection control because you're there because you're sick and you need something to help you get well, right? And so from a primary care perspective, and how many primary care people do we have in this room? I would say it's probably none to zero, right? So particularly infection control has been a hierarchical system that sits at the tertiary site level, very highly specialized, and has not been able to filter down through the secondary ambulatory care into a primary care setting until just recently with the work that we've done in Ontario for those guidelines. And so talk to Vicki after for those particular guidelines. The important part too is when we looked at the response, we needed to make sure that it was our response. It was an Indigenous response. It wasn't a compliance to an accreditation standard that somebody else told us how to run our own healthcare system. I mean, the blessings about colonization has been that we have partnered together to live biculturally, to understand as educated Indigenous individuals that we can leverage those particular technologies and that particular knowledge transfer that we have gained for the betterment of our people, to set them free and to help them to live well with whatever they have. So from an infection control standpoint, we needed to be able to look at what was our response and how were we going to respond, or was this going to be just a knee-jerk reaction to something that we needed to be able to look at and it wouldn't be sustainable. So responding is probably the first thing that we needed to do when we looked at transformation from a relationship perspective. I think the second thing that we needed to do, if I can get the buttons right, is evaluate. So you can respond well, but you need to evaluate. So what's the current state? So along the North Shore, one of the things that we needed to do is we needed to be able to look at a place where critical mass, where we could get enough data to be able to share and lead our decision makings from developing this particular program. And so in our evaluatory current state analysis, we looked at one of our communities, and that was in Garden River First Nation. And thank God every day for Pam Nolan and for Maxine Lesage, who led as champions of infection control to be able to say, you know what, we need a sense of urgency and we need to be able to do this. And we need to be able to create Indigenous key performance indicators of what that particularly looks like. And so in this particular phase, this is when we started to say that we don't have enough in our wheelhouse, we don't have enough in our bundle to be able to move this initiative forward. We don't have enough knowledge, we don't have the tools, we don't have some of the skills, because I don't know if you know how the system of Health Canada and the province from a primary care perspective is funded. It's similar to the tertiary sites where you come from, where it's funded very limitedly. And so from our particular perspective, it's funded none for infection control. When it comes to that, except for your specialty programs like Hep C and so on. So there's no preventative infection control in our particular context, right? So looking at this was asking nurses to go and do again that wonderful thing that managers do the best. How many managers I have in the room? Where we say, hey, do you mind just taking this project on and doing this on the part of the side of your desk? Because I know you're not doing anything else. And I wish you could do this for us. And so again, one of the biggest barriers we had is how do we respond, right? And how do we evaluate when we find the information and actually do something about it without asking staff to, again, put that other hat on to the 15 hats that they're already wearing. And so in the particular evaluation, one of the things that we discovered is we needed help. We needed somebody in this particular context to come and help, and thank God every day that Vicki, Lori, and Rebecca came along through relationship that we built to say, hey, guys, that's what we do best. And from an Indigenous context, we didn't even know what Public Health Ontario was. And we were confused about Public Health Ontario at first because we thought it was the Public Health Unit. And you know, from an Indigenous Health Canada perspective, those are the guys that only come and check our vaccine fridges, or come and help us when there's a cold chain break, and we don't really want them in our clinics because they come and tell us that they're going to take our vaccines away. So again, there was a whole cultural shift that had to happen in our 7 First Nations communities along the North Shore that said, no, Public Health Ontario is not the public health unit. They're not going to come in and they're not going to spot audit every month about what's going on. And so we had to do some education as well around this to help our communities understand what the position of Public Health Ontario was and how they were coming as allies to help us along this journey. So as we move forward, the important part, again, about relationship is the importance of leadership. And as I said to you before, the journey started before where our chiefs got together and our health directors got together and said, we need to do something different. I remember Pam Nolan standing up in a meeting and saying, you know what? At one time, we used to go down the road when we didn't have milk and eggs or butter. We used to go down the road and we used to ask for our neighbors and our partners for that and our other family members. And we don't do that anymore. Same thing from a healthcare perspective. We used to have medicine men and women, scabewases, and those individuals who used to take care of our people when they got sick. That knowledge is dwindling into our communities. And so we don't have the access to that particular knowledge like we used to. And so one of the things she said was, it's time for Anishinabek to reclaim their health for Anishinabek. And so as doing that, our leaders stood up and they said, we need to no longer shut the provincial government out of our communities, but instead what we need to do is we need to be able to build relationships and build relationships with the provincial entities. So this is myself, my executive director, Gloria Daybuch, and Eric Hodgkins, who was the Minister of Health in the province of Ontario, and being able to build relationships with the government, not as a paternalistic relationship, but that of empowerment, of understanding and knowledge transfer as equitable partners. Not equal partners, but equitable partners. And so from an infection control standpoint, because I didn't know everything that Public Health Ontario did, and our teams didn't know that, but they also didn't know all about Anishinabek, right? So we found a good marriage between the two. And so we were able to build those relationships through the leadership of Vicki and her team, and the leadership of us on the North Shore, and also the leaderships within our communities to say, you know what, we're going to do this together, right? Because our mandate, our value and vision was to be able to work together for the well-being of all. That's what mamawezing means. The actual act of working together for the well-being of everybody. And so we started to build relationships, and once again, in a colonial government, trust the government to have the best interests in mind of our people. Because you also have to understand the trauma and tragedy of infection control amongst Indigenous people. And I'm not going to belabor the point, but I'm going to share with you is that infection was used to kill our people. It was used as a weapon to kill our people. And so when we talk about infection control, that leadership is very important, because the idea of leaders in our community, they were the gatekeepers, protectors, like me as a Bear Clan member, to ensure that we are bringing right people in who are going to help us, not wrong people. Because the last time around infection control that we brought people to come and help us, they killed us. And I talked to an individual who was from Newfoundland, and she explained to me the extinction of the Indigenous population of Newfoundland. And so again, we have to be sensitive and careful how we posture ourselves. And from a leadership perspective, we need to know that knowledge, not again as something that you should feel bad about or you should feel shame about, but you should understand that that's the position we're coming from, just as though it would be your family and your particular loved ones, right? So you need to understand that particular context. So moving on, again, one of the things we thought was important was an alignment in our relationship. So again, no harm of Vicki and her team, we would sit down with our teams and we would talk about these wonderful guidelines they have and these wonderful checklists they have. And if you only do these checklists and these guidelines, you're going to have a robust infection control program. And I remember sitting in a meeting, and Vicki's laughing. I told her I wasn't going to share any of these stories, but it's a good story. We were sitting in a meeting, and we were talking about the importance of these checklists and how mainstream has this checklist that if you go through this checklist and you wipe these parts of the exam room and you do the right thing and you train the janitors, you won't have any problems, right? It's almost like the Mr. Clean of infection control, right? These checklists. And so the idea around this is saying, but that's not going to work for us. And it's not because we wanted to be belligerent or just because we're Indigenous, we wanted to throw the flag up and say it's not going to work for us. No, it didn't work for us because the practice of the way that we set up our processes and systems didn't work for us. And so again, taking those recommendations, taking those checklists, and actually going through and doing value stream mapping and process mapping and mapping out how the patients come into our clinics, how our providers go through the exam room, and actually mapping that process out, we were able to contextualize a great tool that started a conversation around infection control in an Indigenous community. So the next thing I'd like to share with you is when you look at aligning your relationships with Indigenous communities around infection control, I think it's important that you don't shove your best practices as being best practice for us, right? Because you know what? We have some best practices that through this experience that Public Health Ontario has gleaned from that knowledge. Because remember, it's built on that mutual reciprocity, the understanding that we come together not as equals, but as equitable partners, which basically means I have just as much as you have, and we're coming together to build this together. So you need to ensure that your guidelines, as well as your protocols and policies, they align with Indigenous values and the Indigenous context. And so the picture I share here is of a canoe, because amongst Anishinabek, we have a traditional teaching called one canoe and 13 moons. So the idea is that we needed to ensure that every member had an understanding and we were all aligned before we started this process and we started this journey. So thank God, again, because of the work that we did and the relationship we did and the mutual learning that we did together, we were all able to get into this canoe together and start paddling together. And so as a part of that, one of the second thing in the relationship that we looked at when in alignment was to our team optimization. So again, there was only 3 members from Public Health Ontario, and they weren't able to help us in the sense of setting it up and building it and giving us money to resource nursing and all those wonderful things. And so one of the things that we did, and I share the picture here because Lois Harrop is the wonderful lady, the nurse on the right-hand side. And the next lady next to her is Judy Gillingham, who's one of our nurse practitioners. Rita Wilson is a community health nurse in my particular community, Mississauga First Nation, Health Canada funded, as well as Rhonda Pelche, who's the manager of health services in my community, again, Health Canada. And that was me, like I said, 2 years ago, leading the charge in infection control. And so one of the things that we decided was, what does an infection control team look like? Because we didn't even have a clue. Right? And so we didn't even understand. So, and what is infection control from this particular context, right? So how do we do this? And what experts do we need to be a part of the team? And so again, with resources and working together, we were able to develop what we call our infection control team. And so in this particular team, because of our integrative worldview that we look at things holistically, we wanted to make sure that our team optimized around the areas of being interprofessional. So, and again, not just interprofessional as a tag word, but interprofessional as a charter that we developed saying whose roles and who is responsible for particular tasks, but also what you were going to do to facilitate that. Because the other thing that's important around creating team around infection control is, again, the idea that we're a federally funded healthcare center and we're a provincially funded healthcare service. And so how do we, as a provincial healthcare Aboriginal Health Access Center, work with a federally funded program that's not responsible or limitedly responsible for infection control? Because you can't force staff who don't have the mandate to do the work, right? Community health nurses and community health reps, that's not in their job description. They're not responsible for that work. They're responsible for prevention and promotion of health and disease, and predominantly diabetes and hypertension, right? In our particular context. And so again, when you're looking at creating your teams, we had a lot of barriers around that. Because a lot of times, and I'll just share a personal story. So we would create these wonderful checklists that we vetted and we test, and we did the rapid cycle testing, and we collected the data around it. And we would leave those checklists, and we would say, hey, oh, by the way, Rita, we'd love for you to run this test next week and then report back to us. Well, we had a particular issue that came up in the community where it was a fall harvest and everybody was going to the bush to harvest their meals for the winter. So again, that wasn't contextually savvy, so we had to learn. Or they didn't have the resources to be able to run those because that week something else happened in the community. And in my community of 1,200 people, there's only one community health nurse. And I know in particularly, working in Morley, for 7,200 people, there's only 6. So which one of them are going to be responsible for infection control? So again, from an advocacy perspective and from team optimization, all of you who are infection control individuals in here advocate for equitable funding around infection control. Because if prevention, in my opinion, starts right there in that exam room where we work in a primary care context so that we can prevent those particular infections from coming. So, in looking at our teams, again, we can share what our team structure was and how we move forward. But the idea around having those discussions and who's responsible and making sure that community health nurses and partners like social work and partners like custodians actually have the training that's been transferred so they understand where you want to go. The next part was a very unique idea around, again, relationship, is this idea around integration. How many of you guys have heard integration? You got to integrate because there's no more money. Huh? Right? I mean, come on, guys. It's, 1:30? I'm not that boring, am I? So the idea around integration was not only integrating with Health Canada programs and integrating with Public Health Ontario and public health units and learning and integrating that way, But guys, the biggest thing that we learned was internally we had to integrate. So as an Aboriginal Health Access Center, primary care is only one wing of our health service delivery model. But is infection control only in primary health care? No? Okay. So as an Aboriginal Health Access Center, we're responsible for behavioral health, we're responsible for geriatric care, we're responsible for community support services, or PT, OT. We're responsible for traditional health and healing. Is there any infection control in traditional health? Do we have to be concerned about that? I mean, the Indigenous people in the room, traditional health and healing, do we have to be concerned with infection control? When we run our ceremonies and our sweats and so on, that's a question we have to ask ourselves. That's a question we asked ourselves. And so when you look at integrating, you can't just isolate infection control to one place and one position. It's not the doctors and the nurses' responsibility. It's all of our responsibility for infection control, management, and prevention. And so I think that was the most important, and I think that's where we spent most of our time in what I would call the war room, was having discussions around professionals, both internally and externally, regarding infection control, and then also integrating and bringing our grandmothers in, our grandfathers in, our Nokomises and our Cookums, and having those discussions, and also bringing the medicine men in our community and having those discussions about this, and also the leaders in our community and having discussions and having tea and moving around and having those discussions so that everybody understood what we were doing. And so again, looking at that is that everybody has and plays a role. And so when I talk about integration, that's what we mean. We mean that we all are responsible. Because remember the quote that the health director I shared with you, Pam Nolan, said? Anishinabek need to reclaim health for Anishinabek. And this idea that we are the ones who are going to move. And so we need to integrate. And so we started out with that particular individuals in that room right there. So there's nurse practitioners in there. There's a plethora of allied health. There's physio. And we had those discussions about how does these guidelines that we're trying to create, and you can also see one of our traditional healers in there regarding infection control, and how do these guidelines have a context in a sweat lodge, or in a shaking tent ceremony, or in a prenatal birth on the land, because our traditional beliefs and our teachings say that midwifery, our babies are born on Anishinabek land, not in hospitals. So how do we make sure that we're working from an Indigenous worldview, and we have our own guidelines to ensure that our babies are born in a good way, that our people are carried in a good way, and that we create our own systems to ensure that infection controls are monitored. And so those are some of the knowledge transfers that we as an Indigenous population were able to transfer back to the provincial bodies and the entities there through integration. And then the opportunities that arose from this were really interesting. So when we looked at the opportunities, we found that through the infection control program, that wasn't just the only opportunity in primary care, but behavioral health from mental health and addiction perspective was thinking about, when we do urinalysis and when we do transitions of pulling people from methadone, 90 milligrams of methadone onto Suboxone, how does infection control play a role in that plan of care? And what does that look like? And then later, having conversations of how do we talk about infection control when we have individuals who are being discharged from hospital and they have particular illnesses that need that requirement. And how do we set ourselves up to do both patient education or client education and provider education around both of this, and how do we work together? So the opportunities as we came about were particularly, and it's not a colloquialism, but it was endless. We were getting opportunities of having these discussions about infection control, and not even just in our particular health services, but in the community. The community started to talk and be more aware that, it's important. Like, I never raised my kids, and you may laugh at me, but I never raised my kids that when you're done washing your hands in a public bathroom, to take the towel off the cloth, put it in your hand, and then take that towel and grab the door and walk out. Like, it wasn't until these last 3 years that I ever knew that was a infection control guideline, that it was proper. We just all take that knowledge for granted. And so I think it's important that we don't take any of that knowledge for granted, because you individuals who sit in this room right now, you have those knowledge, that gold nugget that somebody may need to benefit. And like I said, I thank Vicki and her team, because she had gold nuggets that helped us along the way to help our little Benonjis, our little kids, to be able to understand even what that meant. So integrating daycare into this, talking about how does that work. And so again, infection control is not a primary care issue. It's not a secondary issue. It's not a tertiary issue. Primary control, or infection control and prevention, is a community issue. And how do we be able to mobilize around that? So that's the biggest opportunity that we're doing, continuing today, and I can't talk much about it because we're continuing to do it, is building an opportunity around infection control from a community development standpoint. And so it's very exciting about what we're doing from an Anishinabek point of view. One of the last things I want to share with you is this idea around negotiation. So how do we negotiate? So again, as I shared with you, the importance about when you're funding jobs and you're getting FTE requirements from what we'd call a blended or a hybrid model, you need to be able to negotiate with the government to say, hey, we don't have the funding to do this safe quality practice to our standards, not to your standards, but to our standards. So we have to be able to build the case. So the regional chief, Angus Toulouse, that's him there. He's now the CEO of the North Shore Tribal Council, where I used to work. And so we were able to move with our board to get negotiating with our Northwest LIN, the Northeast Local Health Integrated Network. We were able to work with them and just recently got funded for 7 clinical care coordinators who, as a part of their mandate, is responsible for infection control because of the work we did, because we were able to negotiate and show how important this is. And so negotiation is also important in building of an infection control program in an Indigenous context. And it's not just us internally negotiating externally. It's sometimes negotiating with family members and saying, hey, can you come out to this dinner and understand a little bit about infection control? Well, I don't want to get sick. Why would I go there? I don't want to get sick. No, the idea is that you're going there to learn how to not get sick, Grandma. Okay, well, I'll come, right? So the idea is sometimes we have to negotiate within even our nuclear family members and having those discussions about why is this important and using those local leaders to be able to do that. And I'm not talking about leaders with titles. I'm talking in my context, we have natural Skabewis leaders that do it because that's just something the Creator's divinely given them to lead in our communities. And they do that, and they're called Skabewises, or helpers. And so being able to mobilize on that particular value and that particular leadership as well is important in our context. And then this idea around shared responsibility. So a lot of the conversations that we got in, because I'm sure you're concerned about, well, did you ever have conflict through the 3 years that you tried to do this? Well, we had significant amounts of conflict. And a lot of our conflict arose around this idea that you're telling me that I need to do this in my clinic. No. We're working together to do whatever we create together to do in your context. No. You're telling me that I need to do this in my clinic. Why would I do that? Why are you telling me to do that? So that patronizing idea that a governmental entity is going to tell a First Nation community to do anything, right? Because we're in a nation-to-nation relationship. We're equal partners. So the idea was we spent a lot of resource and a lot of time on this understanding that this is a shared responsibility. That not only is it a shared responsibility between us as Anishinabek, but as external helpers, allies around this. So that's Maxine Lesage, one of our champions in Garden River. Her and I were having conversations at the Great Place, Casino Rama, our good casino in Ontario, if you've ever been there. You're more than welcome to continue to pay for my children to go to post-secondary. I'd love for you to contribute to do that. By the way, for my elders who are in this area, I tried to contribute to the Stony Nakota Resort Casino out here, but I hit a blackjack and I left. So I put that money back with my particular 7 kids, as you can see. But the idea is that it's around that shared responsibility that we're doing this together. That no matter what happens, I'm not going to walk out of the room. I'm not going to leave this relationship, that we're doing this together. That we can have a disagreement. We can mutually say, you know what? I'm going to agree to disagree. I think that's not going to work. And that's okay. But the idea is that you never get ability to walk out of the room and say goodbye to the relationship. Because the idea around the treaty is that we're individuals walking in mutual reciprocity together. And one of the great peace and one of our treaties talks about that, is that we have a canoe, you have a tall ship. We have a way of life with a belief system, you have your belief system. We will travel the same waters together, but we will never come into your ship to tell you how to run your ship, and you'll never come into our ship to tell us how to run our ship. It's called the two-row wampum belt. If you get a chance, it's a fascinating story. You can come down to London or the Woodstock area and learn from the people of the Haudenosaunee, Six Nations, and they do a wonderful 4-day teaching about the two-row wampum. This idea that we're in this together and that we want to do it not only for the betterment of my family, but for the betterment of your family, because you're going to learn as well. And we're going to do this together. And so this idea, we had to talk about it. This idea around harm versus help always came up, right? So we have these wonderful protocols, these near misses, or these serious occurrences that we have. So what do we do with that? I don't know about you guys, but they do occur in our health system where somebody sticks themselves, and we have these protocols and moving forward. Well, that was one of the great lessons we learned through the thing was, are we creating more harm by putting these guidelines into place, or are we actually helping the situation? And I'm telling you, you can sit and talk with Vicki and I after, but it wasn't always black and white. We sometimes didn't know if we were doing more harm by doing this protocol or building this system. Case in point, autoclaving in a primary care context. Right? How many of you think autoclaving would be a good thing? I mean, come on. There's got to be come on. I thought it was a good thing. It's an autoclave. Things are getting sterilized. My people are safe. Like, it's a good thing. Well, lo and behold, we find out it's not a good thing. Because if you don't know how to sterilize appropriately, and you don't have the funding to be able to do the chemical indicators, you're not going to be able to have sterile equipment, right? Or this idea that tourniquets can be used, or these venipuncture tubes. I mean, Vic laughs because this is months, you guys, we had discussions about these tubes you take blood with. And this idea that you have to go to single use. Well, enjoy that conversation with your Indigenous population that you have to go to single use, where we have a creation teaching that tells us that our obligation is to ensure that we don't dump things into Mother Earth. So, and we don't just throw plastic that we don't use, that we can sterilize that plastic through that autoclave that we have that sits in the back that Health Canada bought. And we just opened it 3 years ago because we never got trained on how to use it, right? And one of the funding primary care programs we run in our communities is foot care. And it's amazing that 6 times the amount of foot care in our community have amputees. Is there a correlation? I'm not suggesting that. I'm saying it's interesting for research, if there's any researchers in here. But the idea is having those conversations and ensuring that we would not do more harm and instead we would help. And so the good news is, guess what? We got rid of all the autoclaves, right? And we went to single use. And we built a great relationship with our external partners who know how to sterilize instrumentation. And it's not going to cost us an arm and a leg. And so, again, the H in relationships was to discuss whether harm versus help. And then implementation of change. I talked to this. I just got the 2-minute warning. So if you want more, then encore and we'll go a little bit more. But I got 2 minutes here, so it's rapid fire here. So the idea around implementing change was to be able to, again, take the principles from an Indigenous context that we learned and move it. So if you've heard the announcements in Ontario, those 4 individuals that are in here, if you haven't, because the model of healthcare, and those of my friends over here from Alberta, I assume, are looking at Indigenous primary healthcare because that's the only vehicle I think works for our people. The idea around that is that we announced another 20 integrated Indigenous healthcare teams in the province of Ontario, bringing our number to 30 in the province of Ontario. because our model of healthcare, believe it or not, works better than some of the other models of healthcare. And so that research, if you want to research it and you want the evidence, please look at the Association of Ontario Health Centers. They published a great report that talks about the bringing authority back to Indigenous healthcare. And this idea around holistic medicine, we don't treat the root, or we don't treat the branch, we treat the root. If you treat the soul, the body will come. So this idea around holistic medicine is definitely something that not only benefits Anishinabek, but it benefits the whole world. And those that are doing it are showing the results. And now, like I said to you before, we're getting smarter to be able to build technology to drive our evidence-based solutions when it comes to that. So implementing change, we took this particular program and it's now being implemented in 4 other primary healthcare clinics, 2 of them in Chapleau and 2 of them in Wawa. With 4 First Nations. And so again, they're working really hard. That's at Brunswick House. If we have any Brunswick House members here, First Nation, great community, partnered with us to be able to implement that change. And my partner Stephanie led the charge on that. So again, it's looking at being able to spread that, right? So again, it's not just saying this is transactional, but it's transformative. And last but certainly not least, right? So you work hard every day. Right? You crank out stats. You are the gatekeepers of infection control for your health services. We perform to play. And so the idea around this was that once we did this, you have to recognize champions and staff in your program. Because believe it or not, it's interesting. One of my colleagues here, Diane Gray, sitting in here, and they're doing amazing research from the University of Calgary around burnout on the front line. So the idea is that if you don't recognize staff, when you ask them to go the extra mile, they will burn out higher than you know. You felt it, I felt it, we all have been in that boat. So the idea around this is that we had to celebrate. And so my team is a little quirky, as you can see, it's my fault all the time. So we went and we had fun and we celebrated a day saying, you know what? People told us that it would be impossible, that we wouldn't be able to do it, that why would you start that change? You're going to make a lot of mistakes. You're going to make people upset. Why would you mess with status quo? And if you remember the slide that I shared with you about my personal story, right, was because the pain of not changing, right, was too much to bear. So we needed to change and we needed to move. And so again, thank you so much for listening. Again, I hope that you learned a little bit about our story. And again, like I said, I thank the team members and Vicky and the organizers for allowing our story to come out, because I think that's also important, Suzanne, about companies like yours, like IPAC Canada. As you're strategically planning, maybe Indigenous health can be one of your strategic plans to build allies.